Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Well, we have 5 great questions for you today, Dr. Mingle, so let's jump right into them.
Roll them, Kyle.
So our first question for you today, Dr. Mingle, comes from Susan. And Susan asks, how does Mingle Health recommend addressing the challenges of the APM Performance Pathway, that is the APP, and ensuring compliance?
Great question, Susan. I think there are 2 principal driving forces determining whether or not you meet the APP challenge and qualify to collect your shared savings. The first factor is participant practices. I think that effective participation in your ACO's APP efforts should be addressed contractually. Performance, recoverable documentation, and data delivery should be either rewarded for success or punished when substandard, or both. And I think having some kind of requirement or expectation, ultimately with a threat of dismissal from the group, is important to make this work. Second is data aggregation. You have to be able to collect and aggregate data from all of your participants. Now, the first factor was a cooperation factor. The second is more of a technical and procedural factor. That includes appropriate patient identification and deduplication of patients across practices. So you know that John Smith in practice 1 is the same John Smith in 2 and 3 and 4, and et cetera. The critical decisions here include how you'll do it, what vendor will help you do it, and the question, is it replicable and scalable as your ACO evolves? Expect that over time, you're going to add practices and providers, lose practices and providers, and see turnover in each practice's choice of the critical technology, including EHR, that is electronic health records, and practice management systems, and potentially the availability or lack thereof of an enterprise master patient index to give you an important key across these organizations. Now, if you're a frequent participation in this series of Ask Dr. Mingle, you will know that I recommend MIPS CQMs, or now the Medicare CQMs, from a qualified registry rather than ECQMs. The ECQM processes are just too rigid and too fragile to accommodate all participants in most ACOs, and most are susceptible to failure with even small changes in your technical environment. So with the expected addition, subtraction of practices, change or turnover in critical technology, even the routine upgrade of that technology, any of those things can render the typical technical only ECQM type of approach susceptible to breakdown and major maintenance requirements every year. Thanks, Susan. Great question.
Yeah, thank you, Susan. And our next question for you today, Dr. Mingle, comes from George. And George asks, what is Mingle Health's rejection rate for submissions to CMS?
Great question, George. I can't recall ever having a rejected submission to CMS. Perhaps if we look carefully enough, we'll find evidence of an early rejection that has subsequently been repaired and resubmitted. The nature of the registry reporting process includes we make our routine submissions through an API, an application program interface, that Medicare maintains and we access remotely. There's an nearly instantaneous indication of technical success when we submit to that API. Failed submissions can be repaired and resubmitted as quickly as they can be repaired. So it's often just a resubmission, sometimes a repair of something on our side, sometimes or often, more often these days, a repair on Medicare's side. We've done this long enough and often enough. Technical failures are more likely now to come from faulty code or process on Medicare's side than from our side. We have an annual lively exchange with Medicare as to help them harden their annual coding changes and upkeep. If we are not satisfied with a submission, we can resubmit, overriding the early submission anytime up to the close of the submission window. And we take advantage of that fairly often. Sometimes just as our clients, look at your data, you think, oh, this can't be right, and find some correction that we submit. Perhaps even more often, Medicare changes their guidance documents or their rules essentially on the dime during submission season, and we often have to just search our database, search our submissions for things affected by that change, and resubmit. Um, often, often a fairly quick turnaround within hours or days of awareness of that issue. There's another perspective on this at which we excel. When practices come to us for help submitting, we have a better than 99% track record of building a successful submission with them. In fact, pretty much all of the examples that we don't is a choice by the practice that they've decided that the effort is just too big to and the reward too low to make it worthwhile. But there's typically always, and I'm hesitating because I'm like all the exceptions are flying through, potential exceptions are flying through my head. But it really is true that it's rare that we can't build a submission with a practice interested in building it. Thanks, George. Great question.
Yeah, thank you, George. And our next question for you today, Dr. Mingle, comes from Sally, and it's actually two questions in one. So Sally asks, I'm in solo private practice as a radiation oncologist, and I'm confused when I look at MIPS. Should I be using MIPS CQMs or ECQMs, or should I be using MVPs? Some of the measures I have used in the past are no longer available in traditional MIPS, but only in MVPs.
Great question, Sally. Well, if you've been consuming many of my Ask Dr. Mingle sessions, you'll know that generally I recommend MIPS CQMs over ECQMs. And that remains true in this case. I don't see any advantage of you going to ECQMs rather than MIPS CQMs. MVPs, there's not a radiation oncology MVP yet. So that's out of the question. Although for a brief period of time, anyone, whole groups can be using MVPs. So as a solo practitioner, you too can use that. So if you have an MVP that you can make work, by all means, but there's nothing well suited to a radiation oncologist. You'd be counting on, as you are now, you'll be counting on what we call the halo effect. I'll get into that in a moment. And certainly the four measures that have been retired from general MIPS menu of measures and are now only available in MVP measure sets are preventive care and screening, that is influenza immunization, another screening, breast cancer screening, colorectal cancer screening, and body mass index screening and follow-up plan. Those four all have that dynamic that they've been retired from general MIPS usage, but still maintained for usage in certain MVPs. Now, these measures have never been perfect radiation oncologists. In my experience, these actions are not typically within the expectations of radiation oncologists. You're seeing people for the breast cancer or for the colorectal cancer or others and not ordering the screening test. That's usually up to the primary care provider. But they're good measures for you because they're usually recorded in structured fashion, and many radiation oncologists have access to data that they can report and benefit from in what we call the halo effect. That is, someone else's excellent performance on that, if that data is available to you, can qualify you for a favorable scoring in MIPS. Now, as I said, there's not yet a radiation oncology MVP, so there's no help there. And I expect you can still find 6 measures in MIPS you can report enjoying the same halo dynamics of the 4 measures that have been excluded from your use. It's possibly the best bet that the radiation oncology measure set is your best choice. Medicare has prepared a number of measure sets specific for specialists. They look across their measures and said, we think a radiation oncologist can submit these measures. We think an oncologist, a hematology oncologist, submit these, et cetera, et cetera. And the interesting dynamic of those specialty measure sets is if there's less than 6 measures available to you in those measure sets, reporting those measures is enough. So specifically for the radiation oncology specialty measure set, there are 4 measures. Number 102, avoidance of bone scan for staging low-risk prostate cancer patients. Number 143, pain intensity quantified. Number 144, you establish a plan of care for patients who report pain. And number 226, you're screening for tobacco use and you're intervening when the screen is positive. So those four serve as the only requirements of a radiation oncology specialty measure set. They could be included in an MVP, but they're not yet. But the dynamic of this, if you report those 4 measures, there's no penalty for missing 2 of the typical 6 measure set required of MIPS. They reduce your denominator to 40. That is the number of measures times 10, and you can get a perfect score from that. Or regardless, whatever combined score you get, it's divided by 40, not 60. Now, if you're going to do the measure group, you have to submit all 4 measures. If you miss one of the 4 measures, I'm not sure exactly how they're going to handle it, but it's possible you'll get scored. Your score will reflect 3 missing measures, not only the one from the radiation oncology measure group, but you're no longer getting credit for the measure set because you missed one of the measures. So you may be missing 3 measures, not just one. They'll take your total score and divide it by 60 instead of your total score and divided by 30 or 40. Now, if you have no patients eligible for the measure, and it's hard to imagine that a radiation oncologist isn't going to have pain intensity and the opportunity to have a plan of care for pain in your environment. And of course, every patient is susceptible to tobacco use screening and intervention. So the one that makes a reasonable case study is the possibility that you're not caring for doing prostate cancer patients. So in that case, you can do 3 measures, but not the first one. And you take care of that by reporting a 0/0, a 0 denominator. I have no patients eligible for this measure, and a 0 numerator, no performance because no one is in the group. And when Medicare gets that, they give you credit for the 4 measures, or if for a full measure set, they actually change your denominator to 30, so 3 measures can still give you a perfect score. So that's think hard about that radiation oncology specialty measure set. We'll keep watching for an MVP for you. And good luck with your reporting this year.
Yeah, and thank you for the great question, Sally. Our next question for you today, Dr. Mingle, comes from James. And James asks, I am in a discussion with a vendor that provides integration services for healthcare providers. If the client they are serving has an EHR that does not directly support data exchange with their local health information exchange, that is an HIE, how would they help their client meet the requirements of the MIPS Promoting Interoperability PI HIE measure?
Oh, great question, James. You're making me work on this one. First, a quick review. Promoting interoperability is one of 4 performance categories in the merit-based incentive payment system, or MIPS. The other 3 performance categories are quality, costs, and practice improvement activities. Now, all providers who are subject to MIPS are subject to all 4 performance categories unless they qualify for a specific exception for any one or multiple of the categories. Now, starting with a 2025 performance year, all advanced payment model participants will also be subject to the promoting interoperability or PI performance category. They will be subject to promoting interoperability in all cases, including if they are participating in a MIPS APM or a qualified participant, QP, or partially qualified participant, that is a partial QP, in an advanced APM. Now, the requirement for PI lists 4 objectives, although you should consider it to be 5, and I'll explain that in a moment. The first objective is electronic prescribing. The second is health information exchange. The third is provider to patient exchange, that is giving patients access to their data. The fourth is public health and clinical data exchange. For instance, sending data to your state Center for Disease Control, that is disease reporting, or sending data to your local immunization registry. And though it's not listed as an objective, there are several other requirements that can be lumped together under the heading of infrastructure. And infrastructure includes several required actions and attestations concerning the technical environment and its security. Now, the question you've asked is about the second objective, the health information exchange objective. More specifically, the question is about the second of 3 options providers have for satisfying the HIE objective. To satisfy the HIE objective in promoting interoperability, a provider must achieve any of these options. First, you support electronic referral loops. There's 2 elements to that. You have to achieve both or qualify for one or the other exclusion. And that is, you electronically send health information in support of a patient referral or transfer, and you electronically receive and reconcile health information when accepting a patient referral or transfer. So now the exceptions are if you don't make referrals or don't refer patients at least 100 times during the whatever your reporting period is, be it previously 90 days, now going up to 180 days. You don't need to do this. You have an exception from this. And if you don't accept patients in referral or transfer at least 100 times during the period, you get an exception from that. Now, your next option is bidirectional exchange with a health information organization. That is your HIE, typically. And it means that you need to send them information and receive the information from them about your patients. So that's the second way of dealing with this measure. And the third is to enable exchange under TEFCA. TEFCA is the that's TEFCA, it's Trusted Exchange Framework and Common Agreement. It's a specific national infrastructure for bidirectional HIE. It's got a national scope, not a local, regional, or state approach. So any of those 3 ways can support the HIE objective. Now, the ultimate vision behind this measure is that every EHR come with functionality that can be enabled using an administrative tool, inputting the network address of your HIE, of your health information exchange, or whoever else you're exchanging data with, and designating what information you want to push or send and what information you want to pool or receive. It should be no harder than enabling your email address and your email server in your email client. So think of it in those terms. Now, if your EHR does not come with that functionality, or if it does come but is not adequate for your needs, you have other options that fall generally under 3 categories: buy it, build it, or engage it. To explain, if you're going to buy it, you'll buy a product off the shelf that'll do it. An interface engine is the likely option. You install it, you configure it, you run it. It will operate between the EHR and the HIE, the Health Information Exchange technical environments. You could build it. A skilled software engineer or database engineer should be able to accomplish the same using any of several coding tools or database tools available to them. It will also operate between the practice electronic health record and the HIE technical environments. And third option is to engage a vendor. The vendor will buy it or build it. They will either set it up in the practice environment to connect the practice directly to the HIE, or they will be an intermediary with 3-way connection, receiving and sending data to the practice, and receiving and sending data to the HIE. Now, to get credit for any of those, it has to be operational for at least 180 days in the performance year. Now, the final hurdle to any of these is certification. If it is installed and running, it's not going to count unless it is certified. Somebody has to certify it. It can be the practice, it can be the health system, it can be the HIE, it can be the third-party vendor, it can be the creator of the process who's, well, I guess they become a third-party vendor in that sense. But even if it works, if it's not certified, it doesn't count. Now, certification doesn't need to be a barrier to getting this operational. If your HIE connection works, certification should be achievable. Certification is going to show that you understand the requirements of the data exchange and that your tool works. It's going to show both. It doesn't matter if you've built it or bought it. You'll still need to show that you can make it work with a sample data set. Now, neither certification nor cost of certification is trivial, but the cost isn't astronomical, and the effort is more tedious than it is difficult for someone who knows what they're doing in these areas. Now, the resources for all of your certification questions is www.healthit.gov. That's a site to maintain and containing data about ONC the Office of the National Coordinator requirements for Health IT. Choose a certification of Health IT topic. You'll find a list of the vendors that are approved to certify your process, specification and guidance documents, and legislation and rules underpinning all of it. Now, to get certified, you engage and pay a certification vendor. The vendor will review with you the requirements and your local product functionality. When you agree that you are ready, they will connect remotely and watch you run a test data set through your system. When you get it right, you will be certified. You'll be listed on the healthit.gov website. You'll enter a maintenance of certification program, typically with a vendor that got you certified, that involves an annual fee and less stringent periodic attestation requirements. You will typically not be subject to a direct observation again, unless or until you significantly alter your system or the certification requirements significantly change. Now, any of the involved parties can be the certified party. The EHR can get it certified. The practice or health system can get it certified. The HIE can get it certified, or the third-party vendor can get it certified. In this case, the one you described here, it makes sense to me for a vendor that is setting up HIE connections for multiple healthcare practices and EHRs, that you provide the functionality and obtain the certification to benefit all of the providers, practices, EHRs, and HIEs you serve. But again, in this case, there's a lot of different ways to skin the cat. So thanks for a challenging question.
Yeah, thank you, James. And our final question for you today, Dr. Mingle, comes from Bernice. And Bernice asks, how does Mingle Health go get the data from ACO member practices?
Oh, great question, Bernice. It becomes an interesting exercise in problem solving, and most of us here at Mingle perversely enjoy that challenge. There's always a way. There's always a best way, though the best might not necessarily be an easy way. It generally involves a discussion with each practice of their resources and barriers. Now, it might be self-guided using our self-help tools. Our staff might guide the discussion, or you may have a local technology-oriented infrastructure that can pitch in, like sometimes the ACO can have some staff that helps. That often they learn the approaches from us and then take that from practice to practice. Now, it's always useful to look first for technical interoperability tools that come with the EHR. Now, certification regulations are steadily pushing these to broader availability and better operability, but many remain unusable. Barriers include content that is missing, key data that's required for patient identification, eligibility determination, or performance determination. Documentation and workflows that do not populate structured data fields that can be recovered in these, or excessive cost to purchase the module from the vendor. So, and what I'm saying here is that even though these applications, these capabilities need to be certified by your EHR, certification standards are loose enough that doesn't require that they work. or that you're using it in such a way that it works, or that if it works, you can buy it at a reasonable cost. So these are all barriers to those interoperability standards. Now, most EHRs and practice management systems, where we get most of our data, have innate reporting capabilities. Often they're not suitable for similar reasons that interoperability tools don't often work, but they often can and do produce big raw flat files of data that include the data we require to analyze these measures. In one sense, we can get a list of patients and their demographic capabilities out of practice management system to determine who's eligible for each measure, and we can get data from the EHR from these tools that we can match with to determine the performance. For instance, the hemoglobin A1C measure, if you can give us a list of all your hemoglobin A1Cs in the last year or two with a patient identifier to that, that's typically enough to build the hemoglobin A1C measure. Those data sets you provide to us may be more than we need, but that's fine. It's easy to disregard data, but it's possible to infer data that's not there. Now, all EHRs and practice management systems are built on a database, and every database can be technically queried for the data we need. Think again about those big raw data sets. We can get all of the diabetic patients, all of the hemoglobin A1Cs, all of the immunizations, et cetera, et cetera. Now, it requires read access to the database. That is, whoever's going to pull that data has to be able to get in and has to be able to read it. They don't have to be able to change. They don't have to be able to change it or write to it, but they need to be able to read it. And that's how security is generally configured. You may have no access to the database, read access, or read-write access. Now, that access is often legally denied by contract, or it could be physically blocked by whoever's hosting your application if you're not hosting it yourself, or you may not have access to someone with technical expertise to go get it. Now, that technical expertise to go get it might be available from the vendor, the EHR vendor, or the practice management system vendor, might be available from the host who's managing your technical environment. It might be available from your revenue cycle company or billing company that helps you with your billing. It might be available for hire. You can find people with Epic skills or eClinical work skills or next-gen skills, Allscripts, whatever system you're using. There are people who are familiar with the database and know how to write the technical language that pulls those data sets. Now, if all else fails, chart abstraction is available to anyone with adequate knowledge of medical concepts and the willingness to open and read charts and record the data. And that data is typically recorded on a spreadsheet and provided to the vendor, and those have adequately populated, we can integrate into any group submission, any APP submission, or even a MIPS submission. It can be used as a sole source of data or as a supplemental data to integrate with everything else. So there's almost always a way to do it, and we, again, with a willing client, we can succeed 100% of the time, although the cost, effort, skills can be barriers that you choose not to overcome. Great question. Thank you very much.
Yeah, thank you, Bernice, and thank you to everyone else who contributed their questions to today's episode. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to all of you for the great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.